This next topic, I know you and I have discussed in the past, is the CT scan imaging acting as a possible biomarker for susceptibility to lung decline. We know that many of the low-dose CT scans done for lung cancer screening are finding evidence of emphysema in individuals without any respiratory symptoms, but certainly at risk in view of their smoking history. Do you think there is a role for this finding to be reported in some manner that would alert the clinicians to potential interventions to delay lung decline, such as stronger efforts at smoking cessation in those that are still smoking?
Yeah, I mean, I think CT imaging is part of the answer here, and it's reflected through a couple of things. One, yes, the detection of people who are early in their course or haven't reported symptoms or have never done a breathing test, and identifying those people and thinking through the best treatment, smoking cessation being the highest priority, but then also performing a pulmonary function test in those folks and figuring out if they meet the clinical definition of COPD and applying treatment to reduce their future burden of exacerbations and improve their quality of life and sustain it in the long run. We can detect early pulmonary fibrosis on those same CT scans. You know, pulmonary fibrosis is smoking's a risk factor for pulmonary fibrosis. It's shared with lung cancer, and early application of antifibrotic treatments in people with idiopathic pulmonary fibrosis at least is an important therapy. I mean,
Right.
that's an underdetected disease, and early therapy probably helps. So I think in the screening population, there's a huge opportunity to pick things up. There's also sort of a more novel thought around CT scans that my collaborator, George Washko and Raul San Jose, who we work closely with, you and I both work closely with, have developed a number of CT metrics that using novel machine learning methods can detect the earliest forms of lung injury. So someone gets a screening CT and they may have, you know, if they're fortunate, they don't have any emphysema, fibrosis, or nodules. But if we could apply a novel algorithm that assessed regionally whether they have lung that is injured or susceptible to future problems, then that is perhaps a group that we could target for interception. We're not there. We need to study CT scans in a longitudinal fashion. We just did this in Cardia. We have over 1,000 people who had a scan 10 years after another scan, so mean age 55 and then mean age 45 and then mean age 55, and got two scans separated by 10 years. And we can really start to think about whether early lung injury predicts future problems in that cohort. And then I think that will empower the thought process behind how we view CT scans to not just detect disease, but detect risk of future disease.
Quantitating it, right. Very good.
Yeah.
The last topic I'd like to address is the American Lung Association's lung health cohort study, funded by NHLBI and being run through the ALA's Airways Clinical Research Centers. Can you explain what the study is and what is being monitored? And based on the discussion we just had, how do you see the long-term results of the study playing a role in defining respiratory health?
Yeah. So the lung health cohort, the ALA LHC, as we call it, is a study that we initiated. Now, it was delayed by COVID, so 18 months ago now is when we got our first participant in, or 15 months ago, something like that. And it's a study that is community-based, meaning we just want people who live freely and have nothing wrong with them between the ages of 25 and 35 to come enter a long-term cohort study. So a cohort study, the definition of a cohort study is we take a population that meets certain criteria. The criteria for the lung health cohort are your age is 25 to 35 and you don't already have chronic lung disease. We pick that age range because, as we talked about before, that's the age of peak respiratory health. We want to capture adults at their best. Some of them may have lower reserves. Some of them may have, high reserves. Some may be highly susceptible. But what's really important about it, Al, is one, it's a lung study. Like everything we've done in Cardia is us trying to reverse engineer information from a cardiovascular study. The goals were our cardiovascular. The goals of this study are around lung health, and our phenotypic assessment is related to lung health. Spirometry, a lung CT scan, a discovery biomarker approach that includes sampling of the nasal respiratory epithelium, the nasal lining fluid, as well as the blood, and an ascertainment of exposures and behaviors that we think are important to respiratory health. So vaping, smoking, physical activity, but really importantly, also where someone has lived from birth till now. And then geocoding very specifically those addresses so we can estimate their exposures to airborne pollutants. Maybe in the long run, we can add exposure to airborne allergens and other things that we think influence respiratory health. So we're going to do a baseline assessment of these people with scientific goals of understanding the determinants of peak respiratory health. That is to say, all these life course pollution, pollutants, physical activity, behaviors, does that influence this concept of reserve, the peak respiratory health someone attains in young adulthood? And then in addition, figure out whether people who have lower pulmonary reserve in young adulthood, someone who has lower lung function than someone else, for example, whether that translates to abnormalities on CT scans to really understand what's going on with them and see whether it translates to a different biomarker profile so we can try to understand exactly what's happening. Then, and we're going to have to get more funding to do this, we want to conduct basically what the Framingham study has done for cardiovascular disease for respiratory health and follow these folks the rest of their lives to really understand how this evolves across the life course and identify targets to actually intercept chronic lung disease before it's clinically apparent, i.e., determine what could be the cholesterol for the lung, if you will. It's probably not going to be a single blood measure, but figure that out and then create a platform where we can actually test therapies. We should stop talking about the cholesterol for the lung, Alan. We should start talking about the statin for the lung, but test therapies that can actually stop the progression towards chronic lung disease.